So my name's Ron Lehman here at Columbia. I'm going to be along with Neil Anand from Cedars-Sinai in Los Angeles. We're going to be talking a little about how to achieve lordosis with TLIFs. And so the title of the session is really with deformity applications, but I think like most things, if we can't do a very good job doing a one-level TLIF, it's not going to work as well in these more challenging cases. And so we'll go through a bunch of different examples comparatively, and we'll discuss some of the advantage of this technique. So these are a few things that I've, over the last 10 years, have really changed my practice. If you take special interest there to number 5, highlighted in blue, is that I've realized over time that TLIF is a kyphosing operation. So we really have to do better at this. Certainly by looking at some of the pelvic parameters, it helps us understand how to achieve and what we need to achieve in terms of lordosis, but ultimately we have to be able to affect change and do a much better job of doing this type of surgery. So this is something that we often see. Someone has a 3 or 4 level laterally based surgery and they get adjacent segment degeneration. You know, we tell the patient when they come into the office that, you know, listen, this was bound to happen. You had a fusion. Of course, your level above is going to break down. But ultimately, we have to ask ourselves in the field of spine surgery, is this really a natural history issue or is it our issue? So we can see here with 3 laterally based procedures, those cages are placed right in the middle of vertebral bodies. And no different than when you were a child playing with building blocks. If you stack 9 blocks on top of each other, you can't get it to tilt, right? So you need to make these either trapezoids or do something different. So this is what this particular surgeon ended up with, but what they were really trying to achieve was something that looked more like this. So by restoring lordosis, maybe we can decrease that risk of adjacent segment degeneration. And that's really what we thought until the last few years. And now I think we have some evidence that speaks to that. In addition, I think the GAP score has continued to highlight that we need to have lordosis, but we need to have it in a certain distribution and really in a certain place in the lumbar spine. So different GAP scores are certainly different. We know in terms of mechanical complication, you can have severe disproportionate GAP score and your risk of failure is incredibly high. We also know that the lordosis distribution index helps us look at where do we need it. And most commonly, this is L4 to S1. It varies a little bit depending on the pelvic incidence. And so for patients with a low pelvic incidence or PI, you should have more lordosis from L4 to S1. Patients with a much higher PI, especially those over 60, you can have more lordosis further up or more cephalad in the lumbar spine to really help get your distribution appropriate. And I think this once again goes back to the Rousseli component for the sagittal plane alignment. And if we look at these things and take that into account, this really is not saying anything different. It's just a little bit more scientific at this point. In addition, sacral slope and ideal lumbar lordosis are a little bit different, but once again, they really are predicated upon what the pelvic incidence is and how high or low it is comparatively. So what about adjacent segment degeneration? Like we talked about now, we have a lot of studies that show us even for a 1-level TLIF, the risk of ASD can be 5 times higher if you don't achieve preoperative pelvic tilt of more than 22 degrees. And this has been found in other studies as well, I think, which really sort of highlights this. In some studies, it's shown 9 times higher risk of ASD if you don't achieve lordosis in a 1-level case. So much different than what we used to say, well, hey, it's just a 1-level case. Let's put some screws in, maybe put a cage in, and ultimately, if they fuse, they're going to do great. And we know now that that's not really how this really bears out. So I look at this, when we talk about posterior column osteotomy, when we need to achieve lordosis, and this could be for a 1-level case or for a upper thoracic to pelvic reconstruction, I break this down into sort of 3 types of resections for the PCO. And so, you know, the classic SRS classification for, you know, sagittal plane realignment things talks about sort of 6 different levels. 1 and 2 are sort of PCOs, but I look at this a little bit differently. Facetectomies are things that we perform as we do the surgery itself. We then make a pars cut. This can be much more commonly performed when it's for a TLIF, but oftentimes if we do a PCO, we're going to do this bilaterally. And then the third component is if we need a lot of correction, we can actually take away the superior articulating process or facet as well. This helps us basically create a superforamen. It allows us to do good work in the interbody space. And as we achieve lordosis, this can really help us make sure that we don't have any neural impingement. So how do I do this particular operation? And we'll start with one that's relatively small, but I think it really speaks about the technique and understanding, and then we can extrapolate this into much larger cases comparatively. So this is a case from about 4 years ago, came in with a prior L4-5 ALIF procedure with a posterior spinal fusion. And I think most of us have looked at this in the past and said, well, this is a great result. You know, if this was your patient, they came back to like, well, I took care of the problem. It was at L4-5. I did a, fusion and you're solidly fused. So I basically achieved the goal of the surgery, which is to get you to fuse. But I think there's some other changes here on the X-ray. And Neil, if you maybe want to comment a little bit about, what you see here now that may be even different from, what you would have noticed 20 years ago comparatively.
No, I agree. Like you said, the surgeon did a great job getting a fusion. The instrumentation is great, interbody is great, but I think he didn't pay as much attention to getting the lordosis. And L4-5, as we know, needs a good 15, maybe even 20 degrees of lordosis. I think that's where the issue is, and the effect is seen at L3-4. And I think we learned so much about it, and we've all been prey to this, and we've all done it ourselves. But I think that reaction at 3-4 speaks for itself with the retrolesthesis there because of the lack of lordosis.
Yeah, I think these points are really germane for for we to look at as surgeons, because I think they're a little bit different. We certainly see retrolesthesis, and we know that that's basically the one sign that the X-ray gives us that says the patient isn't able to stand up as well as they need to, and they're really trying to compensate for this. Foramen obviously becomes much smaller, and this patient's actually really hyperlordotic at L3-4 because they're trying to make up for the lost lordosis at L4-5. And then our MRI shows us that they have the typical adjacent segment stenosis, also has some degeneration at 5-1, but with a combination of injections, we really ferret out that the 3-4 is the problem. We also use things like the table to help us achieve lordosis. And so once again, if we can take stress off the screw bone interface, this has to be a good thing. So we flex them to about 30 or 25 degrees to actually do the inner body and decompression. It helps us get in there much better. And then after that, what we do is we take that table and now put it back into relative extension or potentially even more lordosis to help us achieve the correction. And so here was when we start the case. This is, once again, this is prone on the table. So we're at 18 degrees at that 3-4 level. We then, place our screws. We do our TLIF. You can see we performed a posterior column osteotomy, bilateral pars resections. We get our cage, which is a banana cage, all the way to the front. So we use that as a fulcrum and we sort of teeter off of that. And then we begin by using the table to help get the correction first. So we get to 12. We then take it into full lordosis, and now we end up with 20 degrees on the table at that level. And this is just from positioning and really the table coming back into relative lordosis. We drop our rods, do our bilateral rod compression, and now we're up to 24 degrees. And so you can see now we're achieving a lot of lordosis at that level, but you also have to understand what you started out with. And so if you do this exact same case and you get 12 degrees of lordosis, most people would say, well, that's great. I got 12 degrees of lordosis with a TLIF at one level, but you actually kyphose that patient 6 degrees at that particular level. So you have to understand essentially where you're coming from to understand where you're going. And if you don't know that, that's where people get into trouble. And you can see we get quite a bit of lordosis, especially once the patient stands up. They're going to settle a little bit more as well. And so we can see, though, even with a 6-degree lordotic implant, this is the one I used to use about 5 years ago, we, with good technique, can still get a lot of lordosis at one level. Foramen now is much larger as well. And you can see, once again, on the standing film that we get really good correction at that level. We make sure that we palpate with a Woodson to ensure that we don't have any neural compression, especially when we really try hard to get lordosis at 1 and 2 levels through the inner body space, obviously, because we can close down that foramen. So it's important to make sure that you palpate the foramen before you stop to make sure you don't have any postoperative radiculopathy. So what about for larger cases? So for all of these, we actually put patients through the risk calculators, make sure they don't have any perioperative complications that we can optimize ahead of time. We have a monthly meeting that we go over these higher risk patients. And then we look at things, as we know from many studies, that show us that primary cases, in general, do better than revision cases, and especially patients that are less healthy. And so this forest plot, I think, shows us this. This all sort of makes sense. The one area, though, that we can really utilize to optimize a patient in terms of quality of life are patients that have had previous surgery, you're doing revisions. And so someone's had a prior surgery or multiple surgeries and have not been doing well. With a good corrective surgery, that patient's quality of life can really improve. And it's really one of the few sittings that we can say revision cases can sometimes do better than primary cases when it comes to spinal deformity. In addition, we always want to optimize our bone grafting as well. And so the use of biologics, bone grafting strategies to really understand and appreciate where to apply them, how to apply them, taking things into account like the challenge of the patient, vitamin D deficiency, they're smokers, they're a little bit older, you're doing more than 2 or 3 levels, or they have a prior pseudoarthrosis. You really sometimes have to throw the kitchen sink at these patients to get them to fuse, because ultimately if they don't, we're not really quite sure how they'll do over time. And then we get asked sometimes, well, is this a lateral based surgery? Because you can see this cage is a 35 millimeter cage. It's quite large, and it looks like you place this, that Neil did one of these fancy operations where he places it from the side. But once again, these operations are with the TLIF. And now that we have better implants, like the one on the right-hand side, we can do a really good job of achieving lordosis. A nice application that we use intraoperatively to really make this objective is to use these apps. And Medtronic has a really nice one on the Catalyst system called the Lordosis app. And so we can now take a fluoro snapshot of the patient to make sure that we're able to achieve our goals. And so these are ones from the website. You can see that, once again, you can see how much lordosis the patient starts out with, seeing how much you achieve after doing surgery, and ultimately determine if that's really what you need. Now we have implants that actually help us get lordosis, right? So now the Artic-L has options of 5, 10, and 20 degrees. In addition, it has surface technology that allows this to work really well in terms of fusion. And so previous to this, we only had implants that were 0 and 6 degrees of lordosis. And so even with great technique, you can see we can still achieve the lordosis, but now with implants that allow us to get much more angulation, we can do a much better job. And so here's an example of how I do the surgery now, even for an MIS TLIF. This is a 1 level. So once again, Jackie will take a fluoro shot for me. This starts at 7 degrees prone on the table. It was 1 degree standing up. We place our implants. We have our cage. We use our inserter to rotate this around, all the while the inserter attaches to the cage. This is a 20-degree lordotic implant by 35 millimeters long. And once again, through a 1.5-inch incision. We then can use the table and compress, ultimately achieve good lordosis even at this 1 level. And so we start out on the table now with 7 degrees. We ultimately go up to 18 degrees. But this essentially means in this case, we achieve 17 degrees of additional lordosis at 1 level through a 1.5-inch incision. And so you can do this, and you can use this cage, whether you do an open procedure from T10 to the pelvis, a 1 or 2 level open TLIF, or a minimally invasive TLIF. But once again, it's based upon technique and understanding of what you need and what your goals are in terms of achievement. And whether it's this 1 level case, or even something a little bit bigger in terms of 2 levels, where we see we only have 4 degrees of lordosis, and that really just at the 4-5 level. 5-1's completely bone on bone. But once again, with good technique and with proper implants, we can ultimately achieve 32 degrees of additional lordosis from 4 to 1, as the gap score would show us. That's where you need to have it, and that's really what we try to achieve comparatively. And then we can take this and we can extrapolate it to even larger cases. And so we look at this patient. Her BMI is a little bit higher. She's already had cervical surgery. She's coronally and sagittally imbalanced. She's doing everything she possibly can to try to stand up straight. But despite this, she still is relatively flexed in terms of her knees. A little bit closer up view, she's laterally or coronally imbalanced by about 4.5 centimeters. And we know from the Glassman article in 2006 that any coronal imbalance of more than 4 centimeters can decrease your quality of life. And now if we look closely, even at 4-5, you can see it's relatively kyphotic just at that segment, and a more blown up view shows us the exact same thing. So in addition to having anterolisthesis, they also have kyphosis. Furthermore, they have retrolisthesis at 5-1, which is a pretty unusual scenario. Usually you see that the opposite way. And in addition, we have neural compression with severe stenosis at 4-5, as well as some stenosis at 5-1. And so is this a neurogenic problem? Is it a structural problem, or is it both? And probably in this case, I would hazard to say that it really is both. We get a pre-op CT scan, which actually shows improvement of that kyphosis, but it's still kyphotic at 4-5, but has vacuum disc phenomenon, which we know is a good case for the utilization of inner body to make sure that we can get this patient to fuse. In addition, has subchondral cysts, air in the facet joints. This patient's very debilitated by this condition, using everything they can to do it. So in these type of situations, with robotic assistance, we do a L4 to the ilium, decompression at 4-5, 5-1, and then 20-degree lordotic implants at 4-5 and 5-1, and adding the S2 AI screws to help with additional fixation. One, because she had a kyphotic segment to start out, and 2 is that her BMI is a little bit higher, and so she's going to require more in terms of mechanical stability. And so many surgeons will say, well, yeah, that's great, Dr. Lehman, but you just did a 2-level surgery. It's not really a deformity operation. But I would actually probably reword that and say this really is a deformity operation, because by doing a good job of realigning the spine, really in the sagittal plane, you can see now her legs are completely straight, her knees are straight, she's not extending her hips, her gravity line in terms of her skull goes right through her femoral heads, right through her knees, and hopefully this lady now ends up not with a much larger surgery to help correct this. We certainly know that if we do a really poor 4-5 surgery here or a 4-to-1 surgery, she's going to end up with surgery at 3-4, probably within the year, if not 2. Another case that I think can be treated multiple different ways, and we're obviously talking more about TLIFs in this situation, but Neil, what would be your general approach with something like this with about a 30 to 35 degree curve, sagittal balance not too bad, coronally off to the side? How would you typically address this in your practice?
What we do, I mean, I still use a staged approach here, multi-level lateral, single position. It's just that we've got very comfortable with it, but I agree, you can do anything you want, but in our hands, a multi-level lateral approach, 5-1 to L1, 2, and then posteriorly all MIS again, probably T10 to pelvis. And usually we stage it because it helps us evaluate the thoracic component, and I think that's been very, very useful of late.
I think it's a great point. I've actually staged more cases in the last couple months than I have really in my career, and I really like the fact, especially when a patient has radiculopathy pre-op, to be able to assess that in the intervening segments. And so it's really nice that you can break this up into, instead of a 5 or 6 hour operation, to a 1.5 to 2 hour operation, then you come back for 3 hours, because if you don't have to do any neural decompression, those things take some extra time, especially if you're going to use a fancy sort of hybrid construct, certainly like Neil would, where he's going to place percutaneous screws and do some fascicectomies, but not open everything up like I would typically end up doing for a case like this. But you can see on this particular patient, I ended up doing this all posteriorly because I did more aggressive decompressions up to L2, so 4-level decompression, 2-level TLIF, and I think we get overall nice balance in both the coronal and the sagittal plane. And you can see we get quite a bit of lordosis, especially there at the 4-5 level, where she was really pretty collapsed to start out. And then we have patients like this, we have the combination of a thoracolumbar-lumbar curve of about 50 or 55 degrees, but then also have significant thoracic kyphosis, and the kyphosis is a little bit more caudal than normal. So overall, her balance looks really pretty good in the sagittal plane. Her coronal, she's off just a little bit. But then we have, issues like this where do we measure her balance from? Is it really from S1 or is it from L5 in patients with Bertolotti's or sacralization or lumbarization of the bottom segment? And so this patient either has a PIL mismatch of 50 or 80, depending on how we sort of measure it. And I think this really sort of speaks to some of these, the number components don't always add up. So we have to look at this more in terms maybe of the Russell-Lee classification, say, well, this is a little bit higher up. This is a 5 or 6. It's a lot more S-shaped curve, and maybe we have to do something a little bit different comparatively. And then once again, has significant neural compromise, at least of the neuroforamen, all the way up even to L1, L2, and we're pretty aggressive with that comparatively. Our pre-op CT scan shows significant arthrosis, vacuum disc phenomenon, really all the way to even T12. And so these are oftentimes good targets of opportunity to use inner bodies, especially from an anti-psoas or lateral approach, to help achieve good correction, but also to improve really fusion comparatively. And so for this case, I went to the upper thoracic spine, down to the pelvis, and really just did a TLIF at the bottom level, even though I decompressed all the way up to L1 comparatively. Sagittal plane profile, I think we improved this quite a bit as well. And certainly when we look at that, we maintain some harmonious balance of the thoracic kyphosis, the lumbar lordosis, and her gravity line we once again put in place and really make sure that ultimately we balance her. And then once again, this is all from a posterior approach, all of something that we know how to do. And the question really is ultimately, how do we achieve our correction when we look at this comparatively? So we can go to cases like this. I think this is a nice combination of where we could say, well, this is maybe a deformity case because it's probably going to be 5 or 6 levels, but is it really that, or is it a degenerative case? And we see how much degeneration they have at L2, 3, and L1 and 2. This patient has a pretty solid posterior fusion, prior laminectomy there at 4, 5, which we can see. So radiographs really help us quite a bit. Nice posterior lateral fusion here and posterior lateral fusion on the contralateral side at 4.5. So we know they're pretty solidly fused comparatively. So Neil, I'm assuming also in your practice here, this would probably be a nice option for you for lateral or any psoas approach at 2.3, probably 1.2 and 5.1 as well, because they have some retrolithosis there. So you'd probably do that all essentially one day and then come back. Typically Mondays you do the OLIF and then come back Thursday and do the posterior, right? I got your schedule down now. I heard you talk a couple times. I'm running into issues because my OR days now are Tuesdays and Thursdays. I'm not quite sure how to stage these. I have to steal other people's OR time to do it. But I think these are all great approaches. And when we look at the MRI, obviously we can see that 2.3 is the worst level, really has some pretty significant stenosis at that level and significant modic end plate changes at 1.2. So in this case, I'm planning on going 1.2 down to the pelvis. And initially, my plan was just as Neil would do, is do a 5.1 OLIF through the bifurcation and do a 2.3 OLIF and maybe 1.2, although I often have times getting to 1.2 as well because the rib cage gets in my way. I'm not quite as slick as Neil at getting up that high sometimes. So oftentimes I'll just sort of stop at 2.3 and then go posteriorly and do any additional work that we have to do. And so you can see from the CT scan, significant degeneration, subchondral cyst formation, all the things that we are classic when thinking about. And so this patient, which is pretty common in New York and no different than what I'm sure Neil sees in Los Angeles, is that we have anywhere recommendations from MIS decompression all the way to skull to the pelvis, so skull to sacrum type of reconstruction. But I really try to make it based upon what the patient's complaining of, what affects them, and what their lifestyle is. And so in this case, I did a 5.1 OLIF and I went to 2.3, and I actually had a little bit of an issue with the rib cage, and I didn't feel like I could get a good angle. So as a result, I decided to stop there, and we flipped there the same day and actually went posteriorly, and I ended up doing a Lordosing TLIF at 2.3. And so you can see as you zoom up, I don't think I have the zoomed up view. You can see their post-op, but once again, we place a nice big cage. It's a 20-degree lordotic implant at 2.3, and we achieve good correction there of the 2.3 segment. And once again, in this particular case, we use two different approaches, OLIF and TLIF here worked nice for backup for me. And maybe because I've done the TLIF for a lot longer, for close to 20 years, and I'm more comfortable with it and maybe sometimes more aggressive. So if I'm not feeling comfortable doing another technique that I've only done for 5 years or maybe a little bit shorter, like most things, we sort of know what our default is and we'll go back to that. But ultimately, the important thing is to make sure that we keep the patient safe to ultimately achieve the same type of outcome. And so I think this case now really highlights everything that we've talked about. This is a case, unfortunately, 71-year-old gentleman with a movement disorder, not Parkinson's, but Parkinson's-like. We know there's a spectrum now, also on long-term and chronic methotrexate, and had some rheumatoid component, had been on chronic steroids for about 18 months. Unfortunately, had 13 prior surgeries prior to coming to me. And so we can see this particular case because oftentimes we see that he's significantly malaligned. His head is about 20 centimeters anterior to his pelvis. In addition, we look at things like how he looks really from the C7 plumb, which is also out of whack. But 71 years old, his C7 plumb is going to be much different. His gravity line ultimately is the most important thing, and we really found that correlates a lot more with quality of life than in the C7 SVA. But his C2 to C7 SVA is about 7 centimeters as well. We know that should be less than 4. And then we look at things like the T1 tilt. In him, it's a little bit different because we measure off the screws. And if we look closely, we can see here actually that his screws, even at T1, are already about 15 millimeters off the bone. So when we look at the rods, we often look at this and say, well, that doesn't look too bad. It's got to be a cervical problem because his head's hanging off. We look at the lumbar spine, we look at the rods, we're like, they have some lordosis there, so it's probably not that. But we really have to differentiate looking at things like TPA and the C2 or the CTPA as well to say, is this a cervicothoracic problem, or is it a lumbosacral problem, or really is it the rare hybrid where it's both? And so in this particular case, I thought it was both. And I think from your standpoint, Neil, just a quick comment, maybe in the interest of time, do you address typically the cervical first or the lumbar first in a case like this? I think you're still muted.
There you go. No, I'm usually going lumbar first. I think it just makes, for me, just to reassess it, do lumbar first and then go cervical.
Yeah, and I think that's certainly something that Keith Bridwell and Larry Lanke taught me, 16 years ago or whatever in fellowship, is that, you do the lumbar first, and then it's almost like doing the spine reconstruction and total hip. If you do the spine reconstruction first, the total hip is much more modular, and they can sort of put it in artistically. And I think the same thing, we do the larger lumbar surgery. We can then sometimes do the cervical later, and maybe sometimes they don't even need it because they realign themselves quite well. In this case, he was solidly fused, and I was essentially 100% sure that he was going to need a 3-column osteotomy. I just didn't feel like he was healthy enough. And he was just complaining that he felt like his neck was down. And so I knew he was going to need both. I don't like in this type of situation to do a C2 to the pelvis revision with PSO and multiple PCOs in the cervical spine. So I decided to stage him and do him in 2 areas. So I actually did the cervical spine first. And I think this really emphasizes Neil's point, and we knew this going into it, that this was going to be a 2-staged operation. So I did what I thought he could tolerate first, which was the anterior posterior cervical spine. We improved this C2 to C7 SGA to about 4 centimeters, so still not, quote, perfect, maybe perfect for his age. And then because he really didn't do great post-op, we waited about 18 months, and finally he sort of begged at that point. He's like, Doc, even if I don't make it through the surgery, I can't live like this from that perspective. So from that perspective, we decided to do his lumbar reconstruction, and looking at his CT scans, once again, we can see that he really is pretty solidly fused, at least posteriorly, and has multiple OLIF operations done, has some disc spaces down here, which are potentially targets of opportunity, but he has solid posterior fusion mass and has Bertolotti's here at L5S1. And so in your hands, Neil, you see those disc spaces at the bottom. Do you typically try to maximize those and see if you can get something in there and sort of crack it and then go posteriorly, or you say this is going to be a L3 PSO or an L4 PSO because we need a ton of lordosis comparatively?
No, as you said, I'm always looking for that disc. That disc is the best place to manipulate. You suddenly converted a 3-column osteotomy into a interbody fusion with an SPO. I think that's a much less morbid operation than a 3-column, at least in my hands. So yes, I'm always looking for that disc. I'd rather do an SPO and an interbody fusion.
Yeah, and I agree. I thought for sure this was going to be a 3-column osteotomy, so I actually staged him. I was going to come back, do as much as I could the one day, but he had all the implants in. So with the robotic assistance, we got our implants in quite nicely. So that really wasn't an issue. And I ended up doing it all from the back. And so what I did was basically a deformity fusion mass TLIF. So I planned on doing a PSO, but as I started to do and take down the inner body, I realized I was getting a lot of movement. And so you can see we dumped all the rods we had in the hospital into his spine there. We have 5 rods going across that lumbosacral junction. Used the robot to place screws very accurately and very quickly in his fusion mass. And then use multiple dual-headed screws, as you can see here too, to really link these up side to side. So it's a really nice application to do. Added a kickstand rod for some a little bit extra coronal realignment, and we're able to do this all through the inner body, all from a posterior approach without doing a 3-column osteotomy. And you can see now that it makes his cervical spine look so much better when it really looked the same beforehand. But when you teeter him up from a low lumbar spine, you really can achieve good correction. I completely agree. We probably should have done the lumbar spine first. I just didn't think he was healthy enough to do it at that point. So I think ultimately we're really judged by the tools we have in our toolbox. And some surgeons are better at doing certain things. I try to use whatever technique I think works best for that individual patient. I do realize I have limitations compared to someone like Neil, who's very facile with the OLIF and anti-psoas approach. He's always going to be able to do that better than I can. But I do find that there are times when that approach for me is better than a posterior TLIF approach, and sometimes the opposite. And so I think all these things we keep in mind, we really try to use the ultimate thing for the patient, making sure we take the biology and the bone graft component into account as well, that if we achieve fusion, we're ultimately going to have a really good outcome comparatively. Thank you.
Thanks, Ron. That was an excellent review. And like we talked before, I think the biggest message I think we're learning over the years is the ability to manipulate the disc. If there's a disc, manipulated one way or the other. And I think getting that interbody fusion is the best place to get a fusion. So I think the more we're looking at it, that seems to be all leading in that direction. And I think so very eloquently how we can use a TLIF. And the other thing I think a lot of people should take home is the ability to do a TLIF in spite of a posterior fusion mass. Just osteotomize through that mass and you get your TLIF. It still is an interbody fusion. And I think in my eyes, much better than 3-column osteotomy. So yeah, I think the biggest message for me that you gave is, look for that free disc. If there's a disc, go for it. and you can do it through TLIF. And TLIF is a great operation.
Yeah, I think it's.
Should know.
I think it's a great point too, is that one of the things that I found by placing the implants first that I do now with robotic assistance, as opposed to where I used to do it, is that when you have the screw or the screw shank in the pedicle, it basically lights your way to go down. And so it tells you exactly where the interbody space is going to be, whether it's a primary case or revision case. And you go just cephalot that, you go right there on top of the pedicle. You don't need any fluoro. And it really sort of, allows you to, I often equate it to landing, plane on the runway late at night. You can use instruments if you can't see the runway, and it works if you're skilled, but it's often really nice to be able to have the runway lit up and be able to land that plane sort of perfectly. So once again, I think it decreases the stress from my standpoint. So I think,
sometimes, go ahead.
I was going to say, I think we're a little bit over. I'm getting the proverbial shepherd's hook here, but so certainly on behalf of Neil, hopefully this session was beneficial for everyone. And please go back to your agenda and continue with the rest of the program. Thank you.
All right, thank you.